I'm Satish. I'm the head of program for AT Scale, and I'm dialing in from Geneva in Switzerland. A very warm welcome to all of you over the launch of the technical report and the country guidance document on scaling up spectacle provision using handheld autorefractors in low resource settings. One of the questions that we are often asked by countries, policymakers, partners, is how can we scale up access to services, especially at community level, primary healthcare level, hard to reach areas, and how can technology support in that process? In today's webinar, we'll explore one of those options in the space of eye and vision care. But before we begin, some housekeeping notes, which I'm sure all of us know by heart by now, but just a quick reminder. The webinar is for 90 minutes and ends at 10:30 Central European Time. Please keep your microphone muted. The webinar is being translated live in English, French, and Spanish. Please click on the interpretation at the bottom of your Zoom screens to access it. Closed captioning is also available in English, French, and Spanish. Please click on the links in the chat to access that separately on your screens. The webinar is being recorded and will be shared publicly. For any questions, please drop them in the chat. We have team members who are monitoring the question answers in the chat, and they will respond in real time or during the question answer session. And if you are unable to answer any of those questions during the webinar, we'll ensure that we reach out to you individually after the webinar and respond to those queries. Please use the chat function to provide any general comments or feedbacks you may have. Any comments or feedback will be extremely helpful for us as we embark and take this work forward. In today's webinar, we'll have a deep dive and look at the findings of the research work which was done on the handheld autorefractors in low resource settings. This will be presented by LV Prasad Eye Research Institute in India and IQVIA, who have been leading the research work and led to the development of the report as well as the country guidance document in collaboration with AT Scale. This will be followed by discussion on implications of for eye and vision care policy and spectacle provision at the country level. This will be discussed and presented by Ministry of Health in Kenya, who will more present from a policy implication perspective, followed by World Health Organization, responsible for global public health normative work and its implications based on what comes out or stems out from this research. And then we'll move to Sightsavers, who are scaling up programs at the country level, and how this research work and findings influence programs at the country level. And then we'll go to the private sector, which will be represented by EssilorLuxottica. So without taking further time, let me invite our Chief Executive Officer, Pascal Bebel, for opening remarks and setting up the stage on why we are here today. Over to you, Pascal.
Thank you, Satish. Good morning and good afternoon and good evening to everyone joining us today. On behalf of AT Scale and the entire team, it's really my pleasure to welcome you to this webinar to officially launch two important pieces of work: the technical report on handheld autorefractor technologies and the country guidance to scale up spectacle provision using handheld autorefractors in low resource settings. Globally, more than 2 billion people experience vision impairment, with over 1 billion cases of avoidable vision impairment. Strikingly, 90% of people with vision impairment reside in low and middle income countries, where service provision tends to be the weakest. Uncorrected refractive errors are a leading cause of vision impairment in both children and adults, affecting about 88 million people. Uncorrected refractive errors, most of which can be addressed with spectacles, have far-reaching consequences across different age groups and are a crucial public health threat with widespread social implications. However, as WHO reports, 2/3 of people in low-income countries who need spectacles do not have access to them. And one of the reasons for poor access to spectacles and vision correction in low resource settings is the unavailability of trained, highly specialized manpower to carry out traditional refraction methods, retinoscopy, subjective refraction, cycloplegic refraction, etc., which are considered the gold standard, but are challenging to scale in remote, low resource settings. Handheld autorefractors, devices that are compact, user-friendly, and capable of simplifying the refraction process and spectacle prescription, have a huge potential to address this issue. Additionally, the rapid evolution of technologies over the last decade used in handheld autorefractors and their potential integration with advanced technologies such as artificial intelligence and telemedicine offers game-changing opportunities to increase access. And that's why at AT Scale, we commissioned this large-scale, rigorous scientific study. The objective was simple but critical: to objectively evaluate the clinical effectiveness and true scalability of these handheld autorefractor technologies relative to traditional gold standard methods. Today, we're launching the technical report on handheld autorefractor technologies. And this report provides evidence that describes how selected technologies performed in public health settings against the gold standards across different age groups. And moving from evidence to action, we also developed the country guidance based on the study's technical findings, a supplement to the technical report. And this document has been specifically designed with countries, governments, implementing partners, and industry partners in mind, and with a view to how they can benefit from the findings of the technical report. The report and the country guidance before you today are more than a set of technical findings and recommendations. They are, we believe, foundational documents that have the potential to help standardize and accelerate access to eye care and spectacle delivery, and integrate these innovative tools into local health systems in low resource settings. The global market for these devices is already valued at nearly $2 billion, and our work is positioned to ensure this growth translates directly into equitable access to refractive error services and spectacles for the most vulnerable populations. On this note, I want to express sincere gratitude to our partners who drove this effort, the team from IQVIA and the LV Prasad Eye Institute in Hyderabad, and the members of the technical working group. Your dedication to global eye health and assistive technology is what makes this moment possible. I look forward to the discussions today and to learn more on how this evidence and guidance can catalyze real, tangible change in eye and vision care and spectacle provision in low resource settings. I want to wish you all a great session today and hope to see all of you taking full advantage of these resources now and in the future. Thank you very much. Back to you, Satish.
Thank you, Pascal, and thanks for highlighting some of the major challenges on accessing eye care services and how technology can solve this issue. So thank you very much. With this, I would like to invite David Franks, who is the Vice President at IQVIA, for opening remarks. Over to you, David, please.
Thank you, Satish, and thank you to you and Pascal for the warm welcome. We're very delighted to be involved in this work and look forward to sharing more with you later. But first, I wanted to just help you understand IQVIA, who we are, our strategic vision, and particularly the ongoing commitment we have to advancing innovation within the medical technology sector, with particular emphasis on assistive technologies and global health initiatives, which I think this is very much an example of. So IQVIA's mission is to accelerate innovation in service of improved health outcomes worldwide. And we achieve this by leveraging healthcare-grade data, advanced analytics, and artificial intelligence to support the entire life cycle, particularly of medical technologies, from clinical development through to commercialization. Our consulting expertise, coupled with one of the world's most comprehensive healthcare data ecosystems, enables organizations in the medtech space to navigate the complexities of regulatory compliance, reimbursement, and market access. We're also at the forefront of decentralized and hybrid clinical trials. We utilize real-world data to generate robust evidence for regulatory approvals and post-market surveillance, And this approach is especially critical for assistive technologies because we know that patient centricity and usability are essential, in this field. And we have three particular strategic priorities in this area. One is leveraging artificial intelligence and data at scale. So we deploy predictive insights and automation across the clinical, regulatory, and commercial workflows. We're also very much focused on patient centricity. Our decentralized trials and digital engagement tools facilitate broader and much more inclusive participation. And finally, innovation and partnerships. By collaborating with startups and technology leaders, we can integrate assistive technologies into care delivery, enhancing accessibility and personalizing care for those most in need. Beyond the innovation, IQVIA is deeply committed to advancing the global health agenda, particularly in low and middle income countries, where we have a substantial footprint. We leverage our core strengths in data analytics and technology to build sustainable partnerships that foster innovation where it's most urgently required. For example, in South Africa, IQVIA collaborated with the Localization Support Fund to assess the demand for medical technologies. These findings will inform the South African Medical Technology Master Plan, shaping strategies for local production, decrease reliance on imports, and fostering a competitive domestic medtech sector. Additionally, the study identifies obstacles and facilitators to local procurement, such as regulatory challenges and policy incentives, which serve as valuable input for future industrialization policies. In Morocco, for example, we developed agile strategies to scale up HIV self-testing, empowering individuals to take greater control of their health. And across 5 countries, our collaboration with a life science client has expedited the delivery of life-saving HIV rapid diagnostics to millions. In West Africa and South Asia, we've deployed advanced diagnostics for Lassa fever and Nipah virus, bundling solutions for lower-level facilities to enable effective responses to emerging health threats. We're also strengthening bacteriology and antimicrobial stewardship, and we partner with CEPI to build a pandemic preparedness ecosystem that connects needs, tools, and partners to ensure readiness for future crises. Our approach is to scale digital medtech solutions, making care accessible in resource-limited settings. Through these decentralized trial models and digital platforms, we enable device-based care and assistive technologies where they're needed most. We collaborated with HISTRA and our Institute for Human Data Science to identify some of these innovative delivery models, such as community clinics, digital pharmacies that guide scalable interventions for non-communicable diseases using mobile diagnostics, smart devices, and remote monitoring. Furthermore, we foster local innovation through our Innovation Hub and Accelerator programs. We connect medtech startups with our global ecosystem to scale solutions tailored to the unique needs of low and middle income countries. For example, we have an integrated program for chronic kidney disease in sub-Saharan Africa, which places digital health at its core. By leveraging digital tools for healthcare training, patient engagement, and data-driven insights, we've enabled targeted, sustainable interventions in Rwanda, Ghana, and Kenya. This digital-first approach strengthens healthcare systems, accelerates research and policy development, and empowers local leadership, driving lasting improvements in care across the region. So what distinguishes IQVIA is our ability to integrate this real-world evidence, regulatory expertise, and technology into practical, sustainable solutions, ensuring that the medtech innovation really delivers a lasting impact for patients and health systems globally. We remain steadfast in our commitment to closing those access gaps and bringing transformative technologies, such as this autorefractor technology, to the communities that need them most. So thank you very much for your attention, and I'm delighted to be part of this collaboration, and we hope you'll enjoy hearing more about the findings of the work we've done in collaboration with ATscale.
Thank you, David. Thank you very much. And thanks for sharing the drivers of innovation, especially in the space of medical technology sector, and how is it leading to personalized care, health system strengthening, as well as policy changes. So thank you very much for that. Now, let me invite Srinivas Maramulla from LV Prasad Eye Research Institute in India, who led the research team in this work. Srinivas, welcome to the webinar. Great if you can help us understand what is the purpose of this report, who are the main audience of the report, and how can we use the report in the best way possible, and some of the key findings and limitations of the research. Over to you, Srinivas.
Thank you, Satish, and good morning and good afternoon, everyone. I'll present the key findings from the large-scale scientific study on handheld autorefractors. Uncorrected refractive errors are the leading cause of vision loss globally, and we see that in low resource settings, handheld autorefractors have a potential to bridge the gap for uncorrected vision care. There are several studies on autorefractors, but most of them are scattered and they are not done in real-world situations. So to address this lacunae, we have undertaken this large-scale study with 4 major objectives. First objective was to compare the diagnostic accuracy of handheld autorefractors to compare with the gold standard retinoscopy. To evaluate alignment of prescriptions from selected handheld devices with subjective refraction, which we consider as gold standard, and also to assess the feasibility of prescribing glasses based on autorefraction values, and to understand the scale up in public health settings in terms of affordability, skill transfer, and regulatory perspectives. The outcomes that we expect are explore the potential in expanding refractive error services through task sharing to mid-level providers, examine whether the devices which are based on technology, portability, accuracy, and user-friendly interfaces can support direct-to-dispense model, and to inform policy to overcome barriers to refractive errors in low and middle-income countries. Based on a very comprehensive literature review of manufacturers' dossiers, published literature, and also from expert opinions, we shortlisted a universe of 29 models which are there. From that, using a specific criteria, we developed 6 technologies we felt that are useful. And we selected 3 locations: Nigeria, Nepal, and Ethiopia. In each of these locations, the sample size was about 400. 2 autorefractor technologies are implemented in each of these regions. The selection of these technologies was based on some criteria such as accuracy, the weight, the price of the equipment, and time taken to give the autorefractor values. So manual refraction was considered as a gold standard that was done by an experienced optometrist. We included people more than 5 years of age with no ocular pathology and who are able to get 6/12 or better vision with gold standard refraction. Once we ascertained the eligibility criteria, these participants were taken to the other station where we had a community health worker used 2 of the selected devices and performed the assessments. After that, the comprehensive assessments were done by ophthalmologist and routine care was followed. So we used the spherical equivalent refractive error obtained from a subjective refraction as a gold standard and compared that with the handheld autorefractors. In addition, consultations were made with the industry experts, eye care specialists, and other leading organizations in eye care. We also had the stakeholder consultations in India, Pakistan, Indonesia, and Kenya. We had about 400 people selected from each of the locations. Mean age was comparable in all 3 locations. Ideally, a diagnostic test should have a combination of 80% sensitivity and 80% specificity. But for refractive errors, we consider that a combination of sensitivity and specificity of 70% is acceptable. We use a spherical equivalent refractive error for all reporting purposes. A difference in spherical equivalent refractive error of more than 0.5 diopters was considered as was significant. Here we compare the sensitivity and specificity of the handheld device with the gold standard subjective refraction. We use two different definitions for myopia. One is worse than 0.5 diopters, and second definition was worse than 1 diopter. For both these definitions, the wavefront aberrometer and synchroscan had got acceptable sensitivity and specificity. As you can see, almost all of the autorefractors had got very good specificity, but sensitivity was not up to the mark in few of the autorefractors. We used the similar definitions for hypermetropia. Synchroscan had a very good sensitivity and specificity for both the definitions of hypermetropia. Then we compared the sensitivity and specificity of these devices with objective retinoscopy for myopia. Again, we used similar definitions for myopia. One spherical equivalent worse than 0.5 diopters and one worse than 1 diopter. Here also we see that wavefront aberrometer, Shack-Hartman-based technology and autofogging technology performed well. And similar thing was also found for -1 diopters. Similar findings were also noted for manual objective retinoscopy for hypermetropia. Here also synchroscan and autofogging technology performed very, very well for both definitions of hypermetropia. Then we went ahead and looked at the alignment of prescriptions based on Handheld autorefractors and subjective refraction. We divided refractive error into low and moderate grades. As we can see, other than the basal optometer, other devices provided very stable result. If you look at low myopia, all of the readings were within acceptable ranges. However, synchroscan technology had got most accurate values. We also see a similar findings for moderate myopia. However, there's somewhat more variability in the findings. So all devices performed well for low hypermetropia, and similar findings were found for high hypermetropia. But however, we had a fewer number of participants in high hypermetropia groups. When we looked at the age groups, because refractive errors are also based on age groups, and also element of accommodation is present in the younger age groups. If you look at the younger age groups, we see that other than the basal optometer, other refractors performed well, but however, there was large variability in the findings. But as we see in the older age groups, as age increases, the readings become more and more stable and more accurate. If we take as a group, as a one summary metric of these autorefractors, out of the 6 autorefractors selected, other than the basal optometer, all other autorefractors give values which are very much comparable to the subjective refraction. This suggests that based on the spherical equivalent refractive errors, this could have a potential for prescribing ready-made glasses for the adult population. We have seen that in children, the results are variable. And however, with due caution that we can prescribe glasses if at all the vision improves to 6/6 or 6/9. However, we should not be giving glasses for people more than -3 diopters. Our study also had few limitations. We did not evaluate astigmatism. We did not do cyclopic refraction in younger participants. And also, as mentioned, the sample sizes in the higher refractive age groups were smaller, and that limits the generalizability of our findings to those minority of population who tend to have high refractive errors. The next session would be on the country guidance document, recommendations for scaling up the autorefractor technologies. Thank you.
Thank you. Thank you, Srinivas, and thank you for explaining the research and what went behind it, and how what are the some of the parameters which were considered when the research was conducted. So thank you very much for presenting that background. Now I would like to invite Stefania Berada from IQVIA. Stefania, please can you brief us what are the key elements that must be considered beside the technical aspects which Srinivas has already covered in selection of handheld autorefractors in public settings, especially in low resource settings? And what are some of the key recommendations that stem out from this particular study? Over to you, Stefania.
Thank you very much, Sachin. Let me share my screen. I believe you are able to see my screen.
Yes.
Okay, perfect.
Yes.
Thank you. Sorry. Okay, so let me first start by providing some background. It was already touched on by Pascal, but in terms of the global autorefractor market, so in 2023, its value was estimated at 1.9 billion US dollar, and it's expected to grow significantly, reaching more than 5 billion US dollar by 2032. And within this market, the handheld autorefractors are projected to account for $1.2 billion by 2033. So this growth is driven by several factors, including the rising demand for vision care, aging populations, and a greater awareness also about eye health worldwide. So one of the key motivations for the study was the lack of comprehensive data on available handheld autorefractors. So ATScale wanted to explore how expanding the use of these devices, particularly through task shifting to mid-level provider, could ultimately improve access to refractive services. So specifically, we set out to determine whether the handheld autorefractors, and we already, flagged their benefit in terms of combining advanced technology, portability, reliable accuracy, and also intuitive interface. How this use could support a direct-to-dispense approach, meaning that a patient could receive on-the-spot spectacles immediately after testing without needing additional confirmation from a specialist through retinoscopy or subjective refraction. So now let's move to the recommendation that emerged from the study findings. And these recommendations are designed to help countries meet the unmet needs around uncorrected refractive error and to support the immediate dispensing of the spectacles. So we will go through the potential scalability in public health settings, the framework for this scale-up, and the key recommendation and the way forward. So it's important to talk about the concept of task shifting and task sharing in low and middle countries. It's really at the heart of the study and the potential for scalability. So because resources are often limited, there's been really a growing interest in training community health workers and even lay staff to handle basic vision screening and refraction. So tasks that are traditionally performed by optometrists. So this approach also supports the World Health Organization eye care competency framework, which encourages a broader participation in eye care. So, and within that model, the handheld autorefractors play a key role, where the advanced but yet easy to use technology means that less specialized health worker can reliably conduct vision tests, and by lowering the skill threshold, then this device ultimately allow for a safe delegation of vision testing, which helps expand access to refractive services in underserved areas. So although there are several enablers to support the potential of handheld autorefractor to aid in task sharing, still some barriers remain. And so we can see in blue the enablers, so I've touched upon them in terms of task sharing, portability, also healthcare technology, where potentially the opportunity to extend eye care also through telemedicine and mobile clinic, and also the integration with alternative delivery platforms such as screening at school or also referral from primary health center. But there are also barriers that remain, being the weaker supply chain, affordability, maintenance, the devices require long-term maintenance, and also scalability related barriers. So the recommendation that we will present now are really aimed to assist countries in their effort to address or overcome this remaining barrier. So we are going to deep dive into this. So when we consider scaling up the use of this technology and accelerating access to refractive error services and the provision of spectacles, it's really important to look beyond just the core device features, which we have seen are already provided several advantages. So, but factor like how easy the device is to use, its user interface really matter. Also, when we are enabling task sharing with less specialized staff. So, and the broader environment, of course, plays a very key role. So, for instance, the level of support for delegating tasks to different cadres, which really talk to the enabling policing environment for task sharing. Also, how much the supplier know about the market and the devices, so ensuring access to relevant information. And the price point, of course, and whether the device integrates well with other IT systems, really bringing a new technology without creating a silo and ensuring that all the effort that are ongoing in terms of integration, the different system and data flow are strengthened through that integration. So all of these aspects can significantly impact how quickly and widely the handheld autorefractors are adopted, and how well they can also help us meet the need for vision care. So now let's move to look at the 6 recommendations stemming from the study findings. Okay, so this first recommendation really stems from what we are seeing in terms of market access and procurement challenges for handheld autorefractors. So even though the technology itself is widely available, we see that both buyers and suppliers face significant hurdles. So buyers often have trouble sourcing these devices because there's just isn't enough clear information from manufacturers about where and how to purchase them. From the supplier, on the other hand, they struggle to reach a potential customer because they lack the detailed insight into the demand and also what are the most effective sales channels for these technologies. And many countries end up relying, now faced with these challenges, many countries end up relying on local distributors, but who actually may not have been fully familiar with all the available device technology. And then this really brings this disconnect, makes the process even more complicated. And on top of that, in many low resource regions, especially in part of Africa, there's very strict import regulation and we can say cumbersome bureaucratic process, frequently delay or even disrupt the procurement of these devices. So while the devices themselves are out there, this real world barrier can really significantly slow the adoption and limit access where they are needed the most. So the recommendation here is addressed to the manufacturer, really encouraging country stakeholders to collaborate with manufacturer to create that market intelligence platform. There's also a recommendation to custom and excise to leverage best practice to streamline and ease the custom processes and to national government to support with development of policy brief, but also technical document to also really go beyond one ministry, but engage all the relevant ministry to, again, enable a simpler regulatory system to ease the import of the devices. So these are recommendations that can take some time. So that's why the recommendation in terms of the implementation time frame is more in the medium to the long term. Now let's talk about who is actually using the handheld autorefractor in the field. So traditionally, these devices have been in the hand of trained professionals, so being like optometrists or ophthalmic nurses, but and community health worker or non-health staff haven't typically used them. So, but what's been really promising and what our study demonstrates is that in a low resource environment, we can successfully train community health worker and other health care staff actually to use these devices. So it means that the technology isn't limited to highly specialized provider, and instead it's opening the door now for broader adoption, especially in low and middle income countries, and could help extend access to vision care where it's needed the most, overcoming the staff shortages that is unfortunately broadly affecting the countries in low resource environment. So here the recommendation is addressed to the Ministries of Health in terms of creating that enabling environment and policy environment to promote task sharing and also continuous education. Then for the National Eye Program to promote the adoption of a competency-based refractor error approaches, and then to public hospital to develop a curriculum and the use of the technology by primary healthcare, their primary healthcare workforce, and to include it as part of the competency framework. So this is a recommendation that could ideally happen in a shorter time frame in the short to the medium term, so within less than a year to up to 2 years. In terms of the effectiveness of certain technology in community environment, we've seen from the presentation from my colleagues that the study has shown that devices from SynchroScan and Shack-Hartmann wavefront sensing, especially those with open view design, have proven to work well when they're used in the field by community health workers. So we've also seen that other research conducted in various location and setting has looked at different type of autorefractor technology to assess how accurate the diagnostics are. And this collective finding suggests that there's several technology options that can be successfully implemented outside of the specialized clinical setting. So here, the recommendation is addressed to global partners who also have a key role to play to support the online and dynamic guide to inform countries about the advantages of the handheld devices. Also, recommendation toward the national government to rely on the published evidence, but also to facilitate a pilot implementation if they want to explore more the suitability of technology within their context or unique context in the country. And the National Eye Program to consider the use again by mid-level provider and community health worker, and to really ease that process through language support or user interface. And this ideally should be implemented within a short to a medium term. And very importantly, we touched around it a couple of times, but it's important to discuss the the need to have supportive regulations when it comes to handheld autorefractors. So a well-designed regulatory environment really helps make these devices accessible and easier to integrate into national health system. So the regulation don't just affect whether the devices can be imported, but they also set the standard for quality certification and make sure that these devices are included in the public procurement process. Ultimately, the good regulation help ensure that the handheld autorefractor are available in the distribution channel and can also be used effectively and safely in the healthcare service delivery. So here, of course, the recommendation addressed to the regulatory authority within the country and on the continent to develop a regulatory framework, bringing key consideration in terms of certification and quality assurance. Procurement authority also to consider pool procurement, and we are going to touch on that later on because it really has a bigger impact, and for professional and hospital association to already do not, as mentioned before, do not create a silo. So we mentioned it in terms of the information system, but also in terms of the supply chain to really integrate the devices in the existing supply chain processes. And here the timeline would ideally be also short to medium term. Moving to the next recommendation. So, and now looking at affordability. So what are the few strategies we can look at when we think about making the handheld autorefractors more affordable, especially for low and middle income countries? So first, increasing the market competition is important. So if we encourage more manufacturers to offer affordable models, then we will see the price becoming more accessible. Next, also standardizing the component across the devices can help lower the production costs, and we should also make the devices less expensive for the buyers. And finally, it's also critical to support manufacturers who are specifically focused on meeting the needs of low resource setting. And so all these steps together can help ensure that the handheld autorefractor become more affordable and accessible where they are needed the most. And for that reason, the recommendation are addressed to manufacturer in terms of exploring a new model for pricing, procurement authority, of course, promoting transparent pricing, but also we touch on the previous recommendation around the pool procurement, and then professional and hospital association are encouraged to focus on reducing the total cost of ownership where needed. So, and really consider not only the initial purchase price, but all the spare part and the maintenance that are ultimately cost that the hospital will have to cater for. And this recommendation is more complicated and take a bit longer to implement. So it's recommended the time frame is ideally for the medium to the long term. And then coming to the last recommendation. So what our research and the previous studies have shown regarding handheld autorefractors technology, that nearly all of these devices, except for the Badal optometer, so that was in our research, were able to measure refractive error within the clinical acceptable range. However, when we looked at the pediatric population, specifically children between 5 and 16, there was more variability in the reading. So it's also important to mention that, well, as what flagged as one of the limitations, we did not use cyclopedia for children in the study. So and that's the reason, because it's not practical in the large-scale public setting. But so it's really the children, of course, especially on the younger population, like in Africa, it's important to encourage manufacturers to focus on technological enhancement that can minimize the need for performing cycloplegic refraction in children, so they can also benefit from, like adult, for the handheld autorefractor devices and the use in community setting. And then lastly, also not only manufacturer, but from research institution to continue investing in publishing literature and knowledge dissemination, really around to build the body of evidence around emerging technology and how they can also address the needs of the children. And with this, thank you very much for your attention. Thank you.
Thank you, Stephanie. And thank you for the clear recommendations for the government, private sectors, and organizations and agencies who are involved in the space of vision care and interested to scale up spectacle provision in the countries. And also thanks for emphasizing the importance of that technology is one piece of the puzzle, but along that technology has to be coupled with service provision, and in this case, spectacle provision, if we want to move forward with the handheld autorefractor. And also thanks for emphasizing the importance of regulation in this space. The study was clearly done in selected countries and quite representative with representative populations, but the learnings and the guidance which stem out from this particular research can be applied to any country who are interested to scale up use of technology, handheld autorefractors, and scale up spectacle provision. This is the purpose of 80 scale global enabler work, that work which stems out can be applied to all countries who are interested in that space. And I now think it's perfect time to invite different stakeholders who are part of assistive technology ecosystems and involved in the system strengthening efforts in the countries. First, let me invite the government. It's a pleasure to invite Monica Bitok, who's the head of eye health services at the Ministry of Health in Kenya. Monica, if you can help us to understand how country governments can integrate these devices in national school health programs or primary eye care or vision care programs to improve spectacle provision. What support mechanisms we should consider essential when using handheld refraction devices, and how do we ensure that it is used responsibly and sustainably by non-specialist cadres, especially at the community level. Over to you, Monica.
Yeah, thank you. Thank you very much, Satish, and thank you for that very important question. So first, before I even go to the question, allow me just to talk about the coverage for refractive error services, that is quite low. A recent study in Kenya found that the national refractive error coverage, effective refractive error coverage, was 6.7%, and this is similar across the region. So we have so many people out there in need of spectacles, but we are not able to reach them. Then also, based on program-based data, is that most of the time when a patient needs, for example, referral after they've been seen, very few comply. So you get even over 60% not honoring the compliance for the referral. So having these handheld autorefractors, I think for me, is a game changer in the sense that when you see people out there in the outreaches, then some can be refracted and they can get their glasses there and then without need for referral, because then most of them don't honor the referrals. Then again, we also realize that when you refract, then later you come and bring the spectacles. We have so many uncollected spectacles. So if everything can be done in one day, like in one visit, and they are refracted, they get their glasses and they go home, I think then we'll be able to reach more people. So how do we then integrate these the handheld autorefractors to eye care services? So number one is that you already have a number of existing platforms that you can take advantage of. So for a very long time, we've been having community outreaches where patients are mobilized, they are screened, and those with basic conditions are treated, and then the rest referred. And I think these are platforms that we can take advantage of, just incorporating or integrating refractive error services in these outreaches, so that our patients, as patients are seen, they also benefit from refraction and access to glasses. The same for school screening programs. So you have a number of school screening programs, and the same can be applied, just integrating the use of these handheld refractors, and children can be refracted. Those who need glasses can access the ready-to-clip glasses. Then you only refer a few who cannot benefit from glasses at that point. So I think that is really, really important. But even as we do all this, it's important to also know that data protection laws are also come into place, especially for the digital devices that collect information, just to ensure that we are complying with the data protection laws. Yeah. Then the other thing that we could consider using, given that to scale up, we might have to use eye care workers, the general health workers in the primary level. So just doing a pilot training and just seeing how accurate or how well they do. So pilot training before we scale up, I think would really be important, because I think this was a study just to look at the different autorefractors, handheld autorefractors. So I think the next step then should be pilot training, so that when we decide to scale up, then it will be evidence based. Then of course also applying this to telerefraction, and I think this is something that is coming up even in Kenya, that we are having some telerefraction programs where you have an optometrist being able to support primary healthcare workers in rural facilities. So I think the handheld refractors would fit in very well, where the primary health workers can refract and then can be supported remotely by an optometrist. So I think there are many more points, but I probably can speak more in the next, when I get a chance to speak again. Yeah, back to you, Satish.
Thank you, Monica, and thank you emphasizing on what role government should play to improve spectacle provision, and also on your emphasis that this particular technology can be a game changer, and the very important point that if used by non-specialist workers, this needs to be coupled with training. So thank you very much for that points. I think it's perfect time now to listen to experience from an intergovernmental agency perspective, who is responsible for normative work in the space of public health. It's a pleasure to invite you, Stuart Keel, who's leading the work on eye and vision care at World Health Organization here in Geneva, in the headquarters. Over to you, Stuart.
Thank you very much.
If you can specifically brief us, what guidance can WHO provide when handheld autorefractors are deployed by non-specialist providers at the community level? How does this work align with WHO's effort to strengthen assistive technology ecosystem, as well as to integrate eye and vision care in universal health coverage? Over to you, Stuart, now.
Thank you so much, Satish. And thank you also AT Scale, AV, Prasad and IQVIA for this very good contribution to moving this agenda forward, which is a very important agenda. And I wanted to just firstly take a slight step back. At WHO, we know in 2021 there were ambitious new targets for refractive error coverage that were endorsed, a 40 percentage point increase between 2020 and 2030. But the reality is, as we heard from Monica before, that coverage is very low. Our recent data suggests that 2 out of 3 people at least in lower resource settings don't have access to the glasses they need. So arguably, as we've heard throughout the session today, the biggest challenge to reaching this target is around human resources, both shortage and maldistribution. And in the current resource constraints that we face, this is going to become much more of a challenge. So if we hone in on that HR-related challenge, perhaps the biggest bottleneck that we face is refraction. And WHO's initiative that was launched in 2024, the SPECS 2030 initiative, which currently is moving forward in over 30 countries, really has a couple of key recommendations. And amongst those is to strengthen integration of refractive error services at primary healthcare level. And another one is to adopt innovative approaches for technology for screening and refraction. So this report here, as I mentioned before, really is an important step to move this agenda forward. And more specifically, I think, as we've heard throughout the session today, I think this approach and the guidance that this provides helps operationalize some of WHO's existing tools, such as the competency framework for refractive error that was launched this year, and better enabling approaches such as task sharing. So there's some initial thoughts. I'm not sure whether Satish will come back. I had some other considerations, whether there's time to come back to those, but just some initial thoughts from a WHO perspective.
No, go ahead, Stuart. I mean, also, I think we will be interested to hear also from a, how does it contribute in UHC? How does it help in moving towards that agenda at the country level?
Yeah, I think there's a few important considerations, and one of those is that as this report is, the approach of this report is framed, we want to ensure that these tools are not merely another expensive screening tool, but rather we're trying to close the gap in the key bottleneck of refraction. And I think from a WHO perspective, a key next step will be around generating more local data on feasibility effectiveness of the use of these systems, which will help with the advocacy to overcome some of these policy-related challenges. And I wanted to emphasize again what Monica said, the very importance of embedding this technology within broader systems with very clear referral pathways and oversight. Particularly important, as we saw, this technology still has some limitation when it comes to management of refractive error in children, but also we need to make sure that we're referring more complex eye disease cases as well. So I think from our perspective, from WHO specs, I think we are considering the development of standards around performance and usability criteria for autorefractors, which I think will really help guide country stakeholders in selecting the appropriate systems and their use. And also just to mention that we are in December launching some new primary eye care training resources. And I think potentially another role for WHO will be to expand these core training modules to perhaps include some training around, simple training around these autorefraction devices as well. So that we are also encouraging sort of quality adoption of these systems. Thanks, Satish.
Thank you, Stuart. Thank you very much, and thanks for also elaborating on the SPEC 2030 initiative and how this particular research and its finding contributes towards that. The importance which you mentioned around the competency framework, which was on refractive error, which was launched earlier this year, as well as the the very crucial point, which is that this technology and this work needs to be framed around system strengthening, as well as has to be embedded in the system, especially in light of the referral challenges which we see in many parts of the world. So thank you for sharing those thoughts. Now let me move to the non-governmental organization sector, who are often the bridge between innovation and service delivery. And it's my pleasure to invite Sumrana, who is the technical director at Sightsavers and leads the eye and vision care work in many countries across the globe. Sumrana, if you can help us understand how handheld autorefractor can help to close the gap in low resource settings or last mile settings, and what programmatic adaptations have you found most effective in this space? Over to you, Sumrana, please.
Thanks, Satish. Good morning, everyone. Really important question, Satish. I think you will agree that there is no denying that innovation is really crucial for improving access to refractive error services and spectacles. Because what we have learned that it helps us overcome major barriers that we've been talking about, like cost, distance, and a shortage of qualified eye health workforce in the settings where we are working. So I believe that by leveraging new technologies and innovation, we can actually make eye care more efficient, affordable, and widely available, particularly in underserved and remote locations. So devices like handheld autorefractors help us close the vision access gap in low resource setting because they are portable and efficient, and help us to do the mass vision screening and that leads to refraction and follow-up care. Also, they can be really easily transported to mobile clinics, schools, or community centers in last mile area, overcoming the infrastructure-related barriers, which are usually associated with traditional heavy equipment. So we feel that these devices, since they are designed to be simple to operate, they require minimal training. We have used them in our programs. So this has allowed us to decentralize screening efforts and reach a larger volume of patients in a short span of time. We've also found them really effective as part of our in-home examinations or mobile clinics because it helps us to make sure that we are reaching the elderly or persons with disabilities with and improving access to care for them. Another point that we've been hearing throughout this conversation is how important it is to be cost effective, and these devices are comparatively cost effective. So they making them really financially feasible option for resource constraint setting, both in context of health system and for INGOs programming as well. However, what we need to keep in mind is that effective implementation relies on context-specific adaptations. So standardized training protocols are crucial for non-eye care workers, so we can ensure that there is a very close eye on quality of care. We also need to conduct targeted campaigns to raise awareness, not only about the importance of eye health, but also about these digital solutions. So there is a community acceptance for such approaches. That's the only way we'll be able to ensure high participation. Success, we learned, is also going to depend on how well integrated different levels of eye care are within this system. So we heard about it from screening to refraction to spectacle dispensing with a very clear follow-up pathways, because we know that the patient journey should not end at screening or refraction if they need spectacles and if they need follow-up care. So within our programs, that's the way we are looking at these devices, integrating them and using them to see how we can amplify and then scale up access to refractive error services and spectacles in really difficult context where we are working. Thanks.
Thank you, Sumrana, and thank you for emphasizing on the, how the use of this technology along with spectacle provision should be coupled with different service delivery mechanisms, whether they are facility-based or in the community or through outreach services or through mobile services. Also on your importance of the context adaptation and ensuring that it is adapted to that particular context, and not to forget quality as countries and partners move from pilot demonstration to scale up provision in this space. So thank you very much, Sumanana, for those important points. From government to intergovernmental organizations to agencies and organizations who are involved at scaling up vision care at the country level. Now let's move to the private sector. As we all know that private sector has a key role in shaping access to services. Let me invite Helen De Rossi from EssilorLuxottica. EssilorLuxottica is one of the leaders in design, manufacturing, and distribution of vision care products and spectacles. Helen, if you can specifically elaborate on how manufacturers can potentially respond to this cause for devices that are of quality and affordable in the community and low resource settings, especially for large scale procurement, public procurement. Over to you, Helen.
Thank you, Satish. So yeah, for sure, the need to address uncorrected refractive error have created strong demand for accurate, durable, and affordable devices. And manufacturers are actively responding, enabled by, I would say, technological progress. And this combination of public health need and technological capability is reshaping how devices are designed. So maybe let me highlight you major trends. The first, as we discussed already, affordability is being addressed without compromising accuracy. So over the last decade, industry players have simplified optical design, reducing the device size and by consequence the cost, and reducing also calibration needs to lower maintenance and improve field reliability. So this contributed to lower the cost. However, we know that the trade-off between the cost and the performance can be improved thanks to new technologies. So through modular components that can be easily replaced or upgraded are still largely, I would say, aspirational today and not widely available. In the near future, advances in modular optics, new form factors, and also for sure AI-based processing will enable even simpler low-cost system that can maintain high measurement quality with a minimal or no calibration once in the field. So the second trend, and also this was discussed, and the devices are becoming far more robust and portable. So we have long battery life, offline capabilities, minimal maintenance are now essential design criteria. Products are tested in hot, dusty, or humid environment and adapted for non-specialist user. And this brings me to the third trend that Stefania talked about. Companies are now incorporate feedback directly from frontline workers, school screening teams, community health workers, and outreach programs, which helps refine ergonomics, workflows, and robustness in real use. So user-centered design is improving usability of the devices. And on top of that, manufacturers are also expanding across all price points and use cases. For example, at EssilorLuxottica, we are deliberately building a full continuum of solutions from very low-cost tools like ClickCheck, whose efficacy has been demonstrated in peer-reviewed studies, to the next generation of smart portable refraction technologies, and up to advanced remotely controllable for teleoptometry. So this breadth reflects our commitment to evidence-based solutions that work in real-world conditions and ensure we can meet needs across the entire spectrum, from large-scale community screening to high-precision clinical prescription. So last but not least, for sure, there is a clear opportunity to innovate not only at the technology, as it was said previously in the presentation, but also in how these solutions are delivered. Tiered pricing, leasing service bundle are common in other areas of medtech, but from my knowledge, almost none of the manufacturers in this category use them today, and especially for community-level refraction devices or low-income countries. So exploring leasing or subscription format represents a major untapped opportunity to improve affordability, budget stability, and long-term service stability for large-scale screening initiative. So in summary, manufacturers are responding today through frugal innovation, robust design, user-centered development to make accurate, scalable refraction and accessible everywhere. And in the future, innovative form factors, AI processing, new business model will further transform affordability and performance, enabling simple optical system with intuitive workflow, minimal training needs, and little to no calibration, while reducing total cost of ownership for large-scale programs.
Thank you, Ellen, and thank you for emphasizing what manufacturers can do with regards to having user-centered designs and in the space of innovation. And also the importance of what you are trying to do is to come up with full continuum of solutions, and the importance of delivery of solutions at the country level adapted to the country context. The report does highlight that further research and innovations to develop devices that are reliable in case of children are needed. So this is extremely important to hear that the private sector and manufacturers can consider developing the full continuum of solution, which can also be applicable in case of children. So thank you very much. We are doing good on time, which is not always the case, but this is good news that we can take some questions Yes, Helen.
Just because if you want, I can just elaborate a bit on the kids refraction
Yes.
for children if you want, if you have time.
Yes, maybe in a minute.
Okay, no, just because we know that all that ITIS was a big highlight of the report. I wanted to tell a bit what can be done for children. We know that refracting children is uniquely challenging, mainly due to the strong accommodation, limited cooperation also, and manufacturing can take several steps to improve devices that work reliably for kids and all age group. So for sure, accommodation needs specific attention. So cycloplasia is not feasible at scale, and while best practices are well known, current methods are not sufficient. So controlling accommodation can be improved through, we saw it, open view design, distance fixation target, or distance photorefraction. But these approaches still have limitation, and we need to innovate in this domain. For example, developing new fixation stimuli and more effective ways to stabilize accommodation during measurement. Then measurement reliability must improve in real world conditions. The children move, lose fixation, and are easily distracted. So device need faster acquisition, maybe robust focus detection, maybe AI algorithm that reject poor quality frames. Enter the ergonomic and age adapted design matter. And the age, also the data model to train the model on this group of age specifically. You know, children are not small adults, so their accommodation pattern, anatomy, and refractive error distribution require dedicated data set, and we need tailored. So, and just to finish, maybe, as it was said, we are also very convinced that the device must integrate into scalable digital workflow. Connection to digital health system enables longitudinal monitoring, and particularly important for children at risk of myopia progression, and also strengthen referral pathways. So asynchronous connectivity is also essential, allowing data to be captured offline. And okay, I think I need to stop because we are okay. You want to keep
Thank you. No, I
okay.
think that was wonderful. Thank you very much, Helen.
Okay.
Thank you for also emphasizing on what more can be done in case of children refraction. I see few questions from the chat, and I will take some of them. And this first one is for you, Srinivas, and this is on the power limitation on providing instant ready-to-clip glasses, especially in the cases of myopia, hypermetropia, as well as astigmatism. And is there any age limitations for providing instant ready-to-clip glasses, especially for children who have these health conditions?
Thank you. Thank you for the question. And yeah, I think the ready-to-clip glasses typically are available within plus or minus 3 diopters. And also they are based on spherical equivalence. That means you'll not be able to correct astigmatism. So that's what we have used in our study also. We use the spherical equivalent refractive error. And our results also indicated that in lower levels of refractive error, it is more or less safer to give glasses. But if you look at higher errors, like more than 3, 4, 5 diopters, especially myopia, hypermetropia, will not be able to deliver because it's not feasible economically, and technically also it's more challenging. So we don't get accurate values. So in summary, +3 to -3 are the values which you can safely prescribe. And again, children, because of several reasons, we may not be able to give ready-to-clip glasses.
Thank you. Thank you, Srinivas, for that. I see another one, which is on I guess for you, Dr. Monica, from Ministry of Health and more from a government perspective. You did mention about system level changes, example, training and workflow and strengthening referrals that are critical for adoption and use of handheld autorefractors to increase access to refractive error services. Can you please throw some light on potential financing approaches that government can explore to ensure sustained integration of technologies in the national eye health programs? Over to you, Monica.
Okay, thank you, Satish. Yeah, I think the biggest challenge, of course, when we are talking about these equipment and all that is usually the cost. And I think some of the approaches that we can use to mitigate the cost, number one, would be if we can get pooled procurement, because we have so many NGOs like being in one country, working in one country, implementing similar projects in different regions. And you'll find that they all have different suppliers. And if this can be coordinated so that you get a pooled financing, pooled procurement, yeah, just for the benefit of using the economies of scale. When you buy more, it becomes cheaper. So if that can be coordinated, just bringing all the partners together, implementing such projects so that we do pooled financing or pooled procurement, I think that is one innovative approach. The other one is a model that has been used for other equipment, that is the leasing. And I think we've had previously in Kenya a program called the Medical Equipment Supplies Program, where equipment were procured on lease. Yeah, so probably this is something that you can explore, leasing this equipment. And I think this would even be better because with the changing technology, then you're able to also update your equipment with time. Then the other one, now this is in country, is that for Kenya we have what we call the Facility Improvement Fund, and this is where facilities are allowed to generate money and they spend the money within the facility. So if you can have money generated within the I units, ring fenced and used to procure equipment within the I unit, then that would really help in terms of equipping the I units and buying equipment such as this. Yeah, so just also taking advantage of the existing laws within a country, if they are available. And for us now, the ring fencing of the funds generated within the I unit would really help us procure some of these equipment and allow sustainability. And then lastly, of course, evidence-based procurement. I think we really need to capture data, even as we see patients, as we use the various equipment that have been procured, just evidence-based procurement, so that we are procuring equipment that is applicable to our context. Yeah, so that's what I would say in a nutshell. Back to you, Satish.
Thank you, Monica. Thank you. Thank you also on emphasizing the importance of coordination, especially if we want to scale it up at the country level, in keeping low resource settings in mind, and ensuring that all actors and stakeholders who are involved in this space do collaborate and coordinate in this. I see some other questions, and I think they are more related with the research. So I'm going to throw it back to you, either to Stephanie or Srinivas. What is the difference between the wavefront aberrometer and Shack-Hartman wavefront sensing in the report? That's one question. Can you share some details how the clinical teams were trained before conducting the research? How did you ensure that the field teams were well trained? So again, related with training and according to manufacturer's protocol, I think that's a key one. How the team were trained on the ground and how they were trained according to the manufacturer's protocol with regard to the handheld autorefractor. So over to you, one of you, whoever wants to take this.
I will take that, Satish.
Go ahead,
Yeah,
Srinivas. Go ahead.
wavefront aberrometer and Shack-Hartman use a very similar principle. If wavefront of light is thrown onto the retina and the light coming back, the reflector coming back, light is coming back is used for the assessment. There is subtle difference in the technology that is used. Very subtle difference in the way the devices are constructed. Otherwise, principally they are similar. On clinical trains, the teams are trained based on the protocol as provided by the manufacturer, and the training was given in person. Training was given. After the training, we also did a pilot study to ensure that all these things are done on a continuous manner. So we did a small pilot study to ensure that 10% of the sample was where we did all these things under supervision. We also ensured that there's a very strict blinding of findings from one place to other place. So that means that the three important stations are set up, and the coordinator ensured that the subjective refraction findings, the autorefractive findings, and objective refractive findings are completely kept separate. The coordinator has included them at the end of the report. So enough blinding is provided at each and every level to ensure consistency of the readings. I
Right.
think
Thank you.
question also on, I can see that. So Can we clarify whether the glasses can be prescribed solely based on
Yep.
autorefractor results? And that's a very important question.
Yeah.
So our studies has clearly shown that in older age groups specifically, the values are very much comparable. So that is, it is more or less safer to give these glasses in a low resource settings. Ideally, you want to do subject on everyone. Ideally, we want to provide custom-made glasses for everyone. But when you don't have resources, especially in the older age groups, it is relatively safer to do safer to provide these glasses. Younger age groups, we may have to do the subjective refraction before we can dispense the glasses.
Thank you, Srinivas. That was very clear. There's one question, and this is, I guess, for you, Stuart. What role WHO plays in standardizing handheld autorefraction devices to inform quality procurement in the countries?
Yeah, thanks very much, Satish. So as I briefly mentioned before, and this is actually based on a range of consultations with the eye care sector, but also private sector in this space over the last 2 years. WHO is to promote and to promote uptake. WHO is considering the development of standards around performance and also usability criteria for these autorefractors, which would include things like accuracy, durability, data security. And we would do so in order to help guide country stakeholders in selecting these systems and procuring these systems as well. So that's where WHO is moving towards over the next 12 months.
Right. Thank you. Thank you for that, Stuart. I don't see any other questions at the moment. So I think, and there are some which has been responded, so that should be fine. Well, I think we are moving towards the closure, and I really want to thank all the participants who joined today, and thanks for your time, as well as the panelists for sharing your findings and how this work can be taken forward. The English version of this particular technical report and country guidance document will be available online. And the French and Spanish and accessible versions of these reports will be available shortly on our website. The webinar is recorded and will be also publicly available on the AT Scale website, and we'll also ensure that we share it on the social media. We hope that the technical report and the country guidance document will benefit governments, implementing partners, manufacturers, and technical agencies in shaping the eye and vision care programs focused on spectacle provision. And most importantly, we strongly believe that this work will help in reaching the unreached people who are in need of spectacles across the globe. So thank you very much for your time, and thanks for joining today.